Thank you very much. Can you hear me?
Εντάξει.
Can you hear me?
Ναι, εντάξει, εντάξει.
Okay. Sorry. Okay. So, this is the next case. Sorry, I can't be there because I'm recovering from COVID infection. So this next case was performed with the help of the Interbalkan team, Vlasis and Ilias Ninios. So this is about a 46-year-old female who underwent heart transplantation almost 20 years ago and was admitted several times to the hospital due to right heart failure, symptoms of right heart failure. She had peripheral edema, dyspnea. She was almost on 200 milligrams of furosemide daily. And the lab group you see, NT-proBNP was over 2,000, and she had almost cardiorenal hepatic syndrome due to severe tricuspid regurgitation. So after meeting with the heart team to discuss about possible surgery for tricuspid valve surgery, repair or replacement, the U score was high, and the TRI score, which predicts in-hospital mortality for isolated surgery on the tricuspid valve, was very high. So the heart team decided for us to go with the edge-to-edge therapy on the tricuspid valve. This is the baseline echo, as you can see. Sorry. You see a good functioning left ventricle and dilated right ventricle, severe tricuspid regurgitation with a PISA greater than 0.4, regurgitant volume over 50 milliliters. As I said, dilatation of the annulus of the tricuspid valve on both diameters, prolapse of the posterior leaflet, the coaptation gap was 7 millimeters, and there was no chordal rupture identified, even though these patients undergo lots of biopsies, and most of the times we destroy the valve during the biopsy. The right ventricle was dilated with a mildly impaired function. You see the functional area range of 30% and a triangle strain of minus 15%. This is the T screening. We can appreciate here the prolapse of the posterior leaflet with a jet of a severe tricuspid regurgitation going under the atrial portion of the septal leaflet. And as we know from the screening tool from Abbott, the line of coaptation goes through the posteroseptal commissure to the anteroseptal commissure, and we also know that during functional or during tricuspid regurgitation, the annulus dilates towards the lateral wall, the mural wall. So we use the septal leaflet as the anchor leaflet and put most of the times our clips between the septal and the anterior leaflet. And this was our strategy in this patient. Once again, the transgastric view. The aorta is here, the posterior leaflet, the anterior leaflet, the septal leaflet, and the jet comes mostly from the posteroseptal commissure, and this is where our strategy was to put the first clip. This is the data from the right heart cath. You see CVP was 22 millimeters mercury. The pulmonary vascular resistance was 1.16, and the output was not that bad, but still the patient had severe symptoms and sign of right heart failure. This is the procedure. We do the straddling with the catheter, and then you see usually, as Vlasis said this morning, the catheter with the clip goes towards the septum at the beginning of the procedure. So we put some L on the guide catheter, and then we flex down to go away from the septum, then we flex down to the valve, and you see here the line of coaptation. And this is the clip. We are in a transgastric view, and this is the clip with the open arms. We clock it like this. We have to go perpendicular to the line of coaptation. Then we close the grippers, we go in the arms, we go into the ventricle. You see we're in another posterior region. You see here we do independent grasping. First we grasp the posterior leaflet, and you see the grippers here, the septal leaflet, and this is after the grasping. You see there's a good grasp with residual tricuspid regurgitation in the anterior portion of the clip. This is the transgastric view. Once again, you see there is no SLD. The posteroseptal portion is well in the under the arms, and but you can still appreciate that there is a jet just anterior to the first one. So we went for a second clip at this region. This is the second clip. Once again, we do the clocking. We have to go counterclockwise to bring it perpendicular to the line of coaptation. And you can appreciate here nicely that the two clips move in a parallel fashion, meaning that there is no misclocking and that we didn't pinwheel the valve. This is the grasping after the second of the second clip. You see anterior to the first one, the arms are open. And this is the final result. You see the two clips with just a minimal residual trace regurgitation. You see the clips moving in a parallel fashion. And these are the results 9 months after the procedure. You see here the baseline. And you see here just a trace of the two clips with a negative remodeling of the right ventricle. The right ventricle is definitely smaller at the four-chamber view at this dimension with a mild trace AR. Just a few words. TriClip had a CE mark in 2002 and FDA approval in 2020. This is the one randomized illuminated study which showed that it's a very safe procedure when it was compared to medical therapy group. It was very safe. The severity of the tricuspid regurgitation in the arm of the TriClip patients was smaller and the quality of life was better. Just to remind you that there is no place for edge-to-edge tricuspid therapy in the American guidelines, only in European guidelines with the 2B position. And there's not much data on patients undergoing edge-to-edge therapy in tricuspid valve after orthotopic heart transplantation. This is from 7 patients going from 5+ according to this grading scale of Rebecca Hahn, going at 30 days to moderate tricuspid regurgitation. And I just found another case report regarding this group of patients. So there's not much data on patients undergoing edge-to-edge therapy after heart transplantation. Thank you very much for your attention.
Thank you, Dr. Leontiadis. It was a very nicely organized presentation in a very exceptional scenario of heart transplant patient. We have this advantage to deal with this cohort of patients in our center. So it was a nice contribution to this scenario. Any comments from the audience? Okay. So I think that we have to thank Dr.
Do you hear me?
Dr. Chalapas has a comment. Yes. Yes. Dr. Chalapas, yes.
First of all, I want to thank one more time Dr. Iacopo for having me here with you. It is a real privilege. That was a really excellent case, exceptional but excellent case, great result. Opposed to mitral valve, commissural jets in TR are very good candidates for TR procedure. That's just one comment. However, in tricuspid valve area, there are certain issues that we have not yet really answers, like when is the correct time to intervene. This is the first. Which is the optimal medical treatment in right heart failure patients, and of course, which is the best modality in order to evaluate the severity. How often you use cardiac MRI in order to evaluate PR cases? This is just a first question. And the other question is that based on the recently published classification of TR, we have the atrial TR, not ventricular secondary TR. In such cases, devices like cardioband and uroplasty having CE mark could be a good choice. Do you have any comment on that?
About the last question, we don't have experience at Onassis with these patients, but I think that the greatest experience so far is with edge-to-edge therapy. So I think we should go with the technique we're mostly familiar with, and this is edge-to-edge therapy. We don't really use in this setting of patients, we don't really use MRI. I don't think we really need MRI in this patient. And as we know, we have to intervene soon in the disease, because if we intervene lately, then there's a great dilatation of the right ventricle. The right ventricle fails. Then even if we have a very good end result and the procedure, still the patient is not going to go well because of right ventricular failure. So you're going to have a device, a clip, and a walk, or whatever in which is you have a very good successful implantation of a device, but still the patient is not going to do well because he's going to suffer from right ventricular failure, hepatic failure, renal failure, and so on.
Okay. Thank you very much.
So the next